This topic is about seizures. A seizure is a type of hyperexcitation and abnormal neuronal discharge within the brain. Now, a seizure may only occur once for an individual, but some individuals are predisposed to chronic recurrent seizure activity. This is referred to as epilepsy. Regardless of whether a client has a seizure once or has seizures more than once, if that seizure lasts for more than 5 minutes at a time, or there is a rapid succession of seizure activity without a regaining of consciousness, this is referred to as status epilepticus, which is life-threatening and is something that we'll talk about in later slides. There are a number of different reasons why a seizure can occur. Drug intoxication, especially with stimulants, can lead to seizure activity, as well as substance withdrawal, such as from alcohol or benzodiazepines. Tumors within the brain, as well as trauma, can lead to seizure activity, as well as infections and high fever, especially if that infection occurs within the meninges, causing meningitis. Stroke can predispose a client to seizures, as well as any metabolic or electrolyte changes within the body. Specifically, hypoglycemia. Again, the brain really needs that glucose to function properly. Hypocalcemia. And sodium changes, whether that means the client is hyponatremic or hypernatremic. Along with the conditions that we've previously discussed, there are a number of different triggers that can lead to seizure activity, such as strong emotions like fear or anger, if the client is overly stressed or if they go through intense exercise, loud music and flashing lights, a lack of sleep, and again, any fever throughout the body, especially if it's a high fever, which can trigger a febrile seizure, which more commonly occurs within children. There are a number of different types of seizures. Specifically, we want to look at generalized seizures or focal or partial seizures. The types of generalized seizures are tonic-clonic, absence, myoclonic, and atonic, while the types of focal or partial seizures are retained consciousness and altered consciousness. Let's take a look at generalized seizures. Now, when we talk about generalized seizures, these are seizures that are going to affect both hemispheres of the brain. First, let's take a look at tonic-clonic seizures. The symptoms of tonic-clonic features are what we would usually think about when we think of the word seizure. These are going to involve a loss of consciousness as well as a post-ictal state, which is a period of recovery following the seizure. And the most identifying feature of this type of seizure is the tonic phase, which is diffuse muscular contraction throughout the entire body, and especially the limbs, which evolves into the clonic phase, which is limb jerking that occurs especially in the arms and legs. The other types of generalized seizures mentioned here on this slide are a form of tonic-clonic seizures. However, they may lack one or more of the clinical features associated with tonic-clonic. So let's go ahead and take a look at the other three types of generalized seizures. We have absence seizures, which occur more commonly in children. The child or client may appear that they are daydreaming or lost in thought, and oftentimes this brief staring episode is preceded by normal activity or normal conversation. Certain repetitive movements like lip smacking or finger rolling may be present, which is referred to as automatisms. And there is no post-ictal state, meaning there's no recovery period following this seizure. So when a client enters that staring episode, they may only have that for a brief amount of time and then immediately begin resuming whatever activity or conversation that they were involved in. Next, we have myoclonic seizures. Now with this type of seizure, the client usually does not have a loss of consciousness and there is no post-ictal state, meaning there's no recovery period. These type of seizures are defined by brief jerking movements of the limbs and extremities. So this client doesn't have that sudden muscular contraction associated with the tonic phase of tonic-clonic, but they do have that clonic movement, the jerking of the limbs. With this comes a loss of balance and the client is most likely to fall. The last type of seizure is an atonic seizure. Now, we see the word tonic here. However, instead of that intense muscle contraction, we have a sudden loss of muscle function. So the client experiences what's known as a drop attack, meaning that they immediately fall to the ground as they've lost muscle control. Now, let's talk about focal or partial seizures. Now, these type of seizures are only going to involve a single hemisphere of the brain, as opposed to both hemispheres. The first type of focal or partial seizure is a focal awareness seizure. This means that the client maintains awareness during the seizure activity and there is no post-ictal state. With this type of seizure activity, the client may have some involuntary motor function, such as head turning or twitching of other limbs, or the client may have some sensory disturbances, such as changes in smell or taste. The other type of focal or partial seizure is a focal impaired awareness seizure. This is what it sounds like. The client may appear awake, however, they have an alteration of their consciousness, so they may not be aware that the seizure activity is occurring. Again, we may have those automatisms present, being that lip smacking or finger rolling. And with this type of seizure, there is a postictal phase or a recovery phase. We've talked a lot about many different types of seizures. However, let's take a closer look at the tonic-clonic type seizure and how it progresses from beginning to end. Before a tonic-clonic seizure occurs, usually there is a pre-seizure aura that the client experiences. For the client, this can be an indication that seizure activity is going to occur, and there's going to be some slight change within the client's perception, such as they have blurred vision, they could have ringing in the ears, or they may develop something like nausea or a change in smell or taste. This period can last as quickly as a few seconds to a couple of minutes. Following the aura, we get the actual seizure activity. So again, with tonic-clonic seizures, we have that tonic phase, meaning we have that intense muscle rigidity and contraction, followed by the clonic phase, which is the sudden involuntary muscle contractions. During this time, the client can lose consciousness, they can fall if they have been standing or if they were sitting, and they may develop incontinence as they lose that muscle control. This phase usually lasts about 1 minute to 3 minutes, although it can last longer, and it's followed by the post-ictal state, which is that recovery state I was talking about before. During this state, the involuntary muscle contractions and jerking ceases, and the client usually still has some altered level of consciousness. As they slowly regain consciousness, they may be drowsy, confused, or have slowed or slurred speech. When it comes to diagnosing seizure activity, diagnostic tools are going to be used based on what we believe the triggering cause is. A CT scan or MRI of the brain may be used when we suspect head trauma or a tumor. An electroencephalogram or EEG may be used if we suspect that the client has had seizure activity, but we don't know the underlying cause. And an EEG will help us identify when there is a spike or abnormality when it comes to electrical signals within the brain. We should take a closer look at serum electrolyte levels. Again, remember that low calcium, low blood glucose levels, and any change high or low in sodium levels can precipitate seizures. We can check a complete blood count and monitor for infection, typically through a high white blood cell count. And through a urine toxicology screen, we can identify whether the client has drugs within their system. Seizures can lead to a number of complications, and some of them are life-threatening. We've already discussed status epilepticus, which is any seizure activity that lasts for greater than 5 minutes, or seizure activity where we do not regain consciousness but immediately resume more seizure activity. Anoxic brain injury may occur. Due to that muscle contraction, we can constrict the blood vessels and decrease the blood supply traveling to the brain. This can lead to brain tissue hypoxia, leading to that anoxic brain injury. The client may aspirate. During seizure activity, a client is unable to protect their airway, and if the client bites down on their tongue or cheek, this can lead to bleeding, which increases the risk for aspiration. And there are some psychosocial implications when it comes to seizures. So a client may be embarrassed following a seizure, especially if they've had an episode of incontinence. When it comes to managing a seizure, we need to focus on correcting the underlying problem. Now, if a client is actively seizing, one of the first things that we need to do is give a rapid-acting benzodiazepine. One of the most common benzodiazepines that we give is lorazepam. Now, this can be given intravenously if we have IV access or intramuscularly. This medication begins working to reduce and stop seizure activity within the brain. For clients who are predisposed to having seizures, ongoing management involves the use of anticonvulsants such as phenytoin and levetiracetam. For seizures that are unresponsive to pharmacologic therapy, surgery may be necessary. Nursing interventions for seizures are going to vary based on whether we're trying to prevent injury from a seizure or if the client is actively seizing. When it comes to seizure precautions, there are a number of steps that we can take to ensure client safety. First and foremost, we can have oxygen and suction equipment set up at the bedside. Again, because the client cannot protect their airway during a seizure and due to any blood or saliva that accumulates, they're at risk for aspiration. So, we need to be prepared to suction the airway as well as deliver oxygen as needed. It's important that we do things like pad the side rails as well as remove any hazards from the environment on which the client could injure themselves. Movement of the extremities can be so intense during a seizure that a client can actually break bones. This is why we pad those rails and remove those objects. We should also implement any other type of fall precautions, such as placing a bed in the lowest position, as well as activating a bed alarm. Now, it's also important for us to know what to do when a client is actively seizing. If a client begins seizing when they're standing or sitting, we need to immediately go to their side and help them down to the ground, as they can experience injuries from a fall. Once the client is lying down, we need to do our best to clear any objects from the area, again, that could cause injury, as well as try and loosen any restrictive clothing. Again, it's important to maintain not only the client's safety, but your safety as well. So if it's possible, position the client into a side-lying position, which will help blood and saliva trickle out of the mouth and away from the airway. Speaking of airway and preventing injury, we want to avoid placing anything in the client's mouth. The client is most likely going to be biting down with significant force, and if we try and pry the client's mouth open, this can lead to injury of the client as well as the nurse. It used to be taught that we should place a bite block in the mouth. However, when we try and do this, this could lead to chipping of a tooth and again, aspiration. We don't want to restrain the client as this can lead to client injury, and we want to give them as much space as possible. When the seizure starts, if we notice a seizure, we want to time the start of it as well as when it stops. Again, most seizure activity is going to last between 1 to 3 minutes, but if it lasts more than 5 minutes long, that's when we have that status epilepticus and can identify that as a medical emergency. Following the seizure, we need to make sure that we assess the client for any injuries if they have incurred them, as well as make sure that their airway and breathing is maintained. Outside of a clinical setting, it's important to teach clients about preventing seizures, as well as what to do if a seizure should occur at home. This includes identifying those signs or triggers that can lead to seizure activity, alerting emergency response when a seizure lasts for more than 5 minutes. Keeping a seizure diary can not only help the client identify the auras and triggers, but also can help identify the frequency of seizures, which is helpful to report back to the healthcare provider. We should encourage the client to attend relaxation therapy, as well as employ the use of support groups and community resources. It's important for clients who are predisposed to seizure activity to wear a medical alert bracelet, and it's important for the client to follow local driving laws before getting back behind the wheel of a car.